Thank you very much, Dr. Nair sir. It's indeed a privilege and a pleasure to be present here. And in fact, I would say I am equally grateful to you for all the help that you grant to DNB nephrology students across the country. Any amount of educational resources which could be shared with them is not adequate, is what I feel. And I'm always happy to partner with any kind of educational attempt to improve the lot of our DNB nephrology students, because they are hardworking and we need to support them in every possible way. And that's my basic interest. And of course, teaching is a passion. And thank you very much. So without wasting further time, I would like to speak about something which I've been very passionate about over the last many years. I wouldn't say many years, but 4-5 years, ever since xenotransplantation first broke on the scene. A little bit about the history. We are aware that in 1667 was the first recorded xenotransplantation, when this French doctor transfused sheep blood into a 15-year-old boy, and miraculously the patient survived. However, the next two patients died, and thereafter blood transfusion was banned for almost a century, 2 centuries in France. It's only in the later 19th century and the early 20th century when blood transfusion restarted. Thereafter, there have been records of various skin transplants which were used during the 19th century. Mostly they were used for wound dressings. Never ever would the grafts take. They would just cover the skin and prevent further wound damage and improve healing. In 1838, a pig cornea was transplanted to a human being, but we really don't know what the results were like. Thereafter, there was some rejuvenation therapy tried by Russians and even the Americans, basically to in some sort of an endocrine kind of transplant. There were verified reports of improvement. It was not until the early mid-20th century when, in the 1960s, Dr. Keith Riensma transplanted organs from chimpanzees into human beings. Most of them survived just about a few weeks, and the patients either died because of infections or rejection. There was one patient whose kidney survived for 9 months, and the patient died of unrelated causes, and the autopsy showed the graft to be in good health. We have no details about what was the kind of immunosuppression used at that time. Then, of course, this gentleman, Thomas Tazel, we all know him. He used baboon kidneys and livers earlier in the 60s. Again, the same thing. There were no long-term survivors. Thereafter, in 1990s also, he tried 2 adult liver transplants for baboons with tacrolimus, which was a relatively new drug in those days, and the graft survived about 2.5 months. This gentleman, James Hardy, carried out the first lung transplant in human beings, and in 1964, he also moved into the chimpanzee heart transplant into a marginal recipient, but the size mismatch was so bad that the patient died very soon, and thereafter there was very poor public response for the procedure. Then, of course, the greatest showman of organ transplantation, Christian Barnard, broke onto the scene, who did the first human cardiac allotransplant. Then he also followed it up with 2 cardiac xenotransplants from a baboon and a chimpanzee. Unfortunately, we don't know what happened to them, but must not have been good, because the showman that he was, if anything had been good, it would have been publicized. Then Leonard Bailey from Loma Linda University transplanted a baboon heart into an infant girl, which lasted just about 3 weeks. And unlike the previous situations where a graft failed in a heart transplant, this one actually brought public attention to the poor pediatric organ transplant programs, and this led to a very successful pediatric cardiac allotransplantation program in the Loma Linda University. It became a leader in the US in the 1980s. So, ladies and gentlemen, xenotransplantation had a checkered history from the early 17th century all the way till 1992. I have highlighted each one of them, how it happened. But what is interesting is, why don't these xenografts survive? So we know that barriers across species are very important and difficult to overcome. The simplest thing is, most of them have hyperacute rejection, which is rejection within a few minutes. And why does that happen? It happens basically because of preformed anti-donor antibodies which exist in the recipient to the graft vascular endothelial cells. And which is this antigen? Usually it's a carbohydrate epitope called the galactose alpha-1,3 galactose gal, alpha-gal or alpha-1,3 gal it is called, which is expressed on the pig vascular endothelium. Interestingly, this oligosaccharide is present in all mammals except human beings and old world non-human primates, which are the great apes and the baboons. We've lost this GAL expression several million years ago, probably related to a genetic mutation. But whenever an organ which contains alpha-3 GAL enters our system, we immediately our immune system mounts a hyperacute rejection to it because there are anti-GAL antibodies already existing within us. Of course, now, which is why if you notice all the xenografts of the early 60s, 70s and 80s were from old world non-human primates, baboons and chimpanzees. So the alpha-GAL did not have a problem. But what happened to the organs from these animals? There was, of course, acute humoral rejection because of antigens, antibody and complement deposition, the innate immune related damage, and the adaptive immune response thereafter followed up, which ultimately led to vascular endothelial damage and coagulation dysfunction because the graft vascular endothelium is damaged, and this leads to activation of coagulation, and the microvasculature of the graft is destroyed. This is nothing new to all of us nephrologists. We know that this is how the immune system acts against anything which activates it. So what are the obstacles to xenotransplantation? I have, of course, already told you about the immune-mediated organ rejection, but another thing is virus transmission. Just like human beings, when we get CMV infection or we get chickenpox or herpes infections, we get the acute infection, thereafter it subsides and it goes to rest and becomes quiescent in the human being. It can revive itself whenever there is a stress or an immune modulation or an immune suppression. Similarly, there are retroviruses which are endogenous, CMV viruses which are endogenous to mammals of other species. These can also get activated. So this is called xenozoonosis. That is, you acquire an infection which came from a animal species, organ species of a different species. The immune-mediated rejection. So what can we do to overcome these barriers? The first and foremost for us is to select the correct animal. So the previous investigators believed that by looking at old world non-human primates, they were actually selecting the correct animal. But if they had listened to Winston Churchill, or if they had read George Orwell, they would have realized that at the end of the day, a man is possibly closer to a pig than to a primate. So when you compare the two, between a pig and a baboon, what we know is pigs can be bred very fast. They mature very fast, almost 12 times faster than a baboon. The duration of pregnancy is half as much. They produce almost 10 to 12 times the number of offspring. They grow very rapidly to maturity. Their availability is unlimited. We have been rearing pigs for centuries, while primates generally live in the wild away from us. More importantly, the size of the pig organ is very similar to that of an adult human, while that of a non-world primate, because of their size, is usually inadequate. The cost of maintenance of a primate in a lab is very, very high as compared to those of pigs. Of course, I'm not talking of the specific pathogen-free kind of pigs that are being grown now. That's a different story. We'll come to that later. The anatomical and physiological similarity, of course, the primates are very close, but the pigs don't lag far too behind. More importantly, because we have been rearing pigs for centuries and doing experiments on them, we have an excellent in-depth awareness of its tissue typing, and we have done genetic engineering on them, initially for growing them for food to sort of lead to the expression of certain desirable factors, and now we have led to genetic interventions to try and humanize the organ. Next, we can actually grow them in SPF, that is sterile pathogen-free facilities, and hence the risk of xenozoonosis is very low, while primates usually are caught in the wild and then bred in the lab, and hence the chance of xenozoonosis always remains high. And yes, public opinion, because they so resemble us, is much more in disfavor if we would start using organs from primates. What are the advantages of a porcina? It would be very interesting for you to know that the vasculature and the drainage of the pig kidney is exactly the same as humans. The concentration ability is almost exactly the same at 1080 milliosmoles. The GFR is actually slightly higher, but the end result of serum electrolytes and creatinine is identical. When you look at the heart, the anatomy of the heart, especially the coronary vasculature and the chambers and the musculature, is very similar. The mean arterial pressure, the heart rate, the myocardial blood flow are identical. And there is no major difference in functioning when the heart goes from a horizontal alignment in a pig towards a vertical alignment in a human host. There is a mild difference in the electrical activity, but it has no practical consequence. I will not go into the details, but rest assured that all the lab parameters, whether it's electrolytes, renal function, blood gases, liver function tests, albumin, cholesterol, coagulation, D-dimer, fibrinogen, they are almost entirely comparable. So how do you go about humanizing an organ? Now, this is where science becomes more interesting. There is something called a CRISPR-Cas9 system. I would request, for want of time, I'm not going into the details of it, but this is the one, the discoverers of this system, they got it out of bacteria which were being used in the dairy industry. They were awarded the Nobel in 2022. You can basically use it as a cut paste for genetic material. You can cut the the genetic material of the organism wherever you want to what is called knockout unwanted genetic sequences, and you can paste wanted genetic sequences exactly where you want it. So it is called multiplex gene editing, which is what is done first to get this kind of a genetic material into the organ or the animal that we desire. Thereafter, we confirm that the genetic integration is precise. That is, we look at the sequences that were added, subtracted, or modified. We look at the properties and quantities of the gene product which is produced by each cell and ensure that the exact location at which the payloads have been integrated into the genome. Thereafter, there is a process of control and verification, and finally, it leads to the organ production. This is very simply how a very complicated thing is carried out. So what are the things they do actually to make the organ more human? What has been found is pig organs do not express enough amount of complement regulatory proteins. We all know from our PNH classes, CD55, CD59, these are the CD markers which protect the cell membrane from complement related damage. So we introduce genes which lead to an overexpression of these molecules. The next comes, of course, ways to either remove galactose, alpha-1,3 galactosyl transferase, or mask it or delete it. The third thing they do is they make all the organs express blood group antigen type O. That means you now have universal recipient organs, donor organs. So all porcine organs which are grown in a lab express blood group antigen type O. So there is no problem of ABO incompatibility. Then you can, of course, knock out the galactosyl transferase gene, or there are three other methods where you can remove these genes and reduce or completely mask the expression of the gal antigen. You can suppress the cellular immune response by either suppression of the gene expression or downregulate it completely to remove the class 2 antigens, to knock out the class 1, reduce its affinity to human fast ligand, and so on and so forth. Then you can make the endothelium more anticoagulant and less inflammatory by either causing expression of genes which activate this or delete those which increase this. You can also include anticoagulation, anti-inflammatory, and anti-apoptotic gene expressions, which ensure that the overall immune response initiated by this organ is much less than what would have been without any of these. And lastly, using small interference RNAs, we can inactivate various endogenous viruses which are known to exist in these animals. Of course, there is a regulatory aspect which I shall not cover here, but suffice it to say that the FDA and the European regulatory agencies have taken note of the fact that this is a form of therapy and it needs to be regulated. So this was the first report that came from the Massachusetts General Hospital group, where they used humanized porcine donors organs and they used it in cynomolgus monkeys, and they looked at the survival of the organ and the animal and euthanized them and looked for the various immune reactions and other responses that would occur in the organ. So what is simply known as the pigs that are used for this are not those pigs which roam around in our streets and eat from the sewers and the drains, but a specific species called the Yucatan miniature pigs. They are much smaller in size. Another thing which is very interesting is pig organs continue to grow throughout the life of the pig. And hence, it is important to eliminate the growth hormone gene in these pigs so that the human growth hormone does not, otherwise, can you imagine you get a kidney which weighs 150 grams and 10 years down the line, you have a kidney which weighs 300 grams. So you knock out the growth hormone genes. All the three glycans genes have been removed. They do retroviral inactivation. And of course, they have used down-regulated the response to human thrombin and protein C. There are, of course, practical issues with follow-up of these grafts. They don't know how to report rejection because the BANS criteria were not validated for them, so they had to make their own criteria. Next is when they did euthanized these non-human primates in the lab, they noticed that the T-cell mediated rejection was not a very major problem in these grafts. What is more important is they've noticed TMA was more common. Though in an allotransplant, in an allograft, TMA is a sign of ABMR. We all know that, antibody-mediated rejection. But in a xenotransplant, it actually could be because of complement regulatory protein incompatibility or a coagulation cascade protein incompatibility. Of course, they noticed that all the grafts showed C4D staining. So they realized that it's something possibly akin to ABO incompatibility, but there is some co-stimulation that is happening. So they decided that for using these organs in humans, co-stimulation blockade is going to be very, very important. So to quote Keith Reemsma, the person who started xenotransplantation in the 60s, he said that he was very confident that xenotransplantation will succeed. He knew that, but it was just that how utilizable would it be and would it provide us predictable results to warrant clinical application? And that's when the baby steps started. I remember this. This was just around the time the Indian Society of Nephrology conference was held in Chennai in December 2021. The New York University Langone Transplant Institute burst onto the scene and declared that they had done 2 successful pig kidney transplants into brain-dead human beings. Basically, they took brain-dead recipients who were there for some other reasons, and they transplanted these genetically modified pig organs into them. This team was led by Robert Montgomery. He's a cardiac surgeon by profession. He himself is actually a cardiac transplant recipient and had suffered from chronic hepatitis C and had received directly acting antiretrovirus and cleared the infection. Their report was published in the NEJM in the following year. For all of us who have seen the kidney on the bench, this is the most heartening sight to a transplant surgeon and a nephrologist. This was recipient 1 and 2. This was the graft biopsy of the recipient 1. You can see how clean the grafts are. These are peritubular capillaries which have been marked. They're absolutely collapsed. There is no peritubular capillary inflammation. The glomeruli look slightly more blue, but there is really no glomerulitis. The capillaries are all nice and collapsed. The tubules are good. There is no interstitial inflammation. There is no C4D, and the electron microscopy was also normal. So what did they use? They used something called a thymo kidney, which was produced by United Therapeutics. Basically, what they did is 2 months prior to the euthanization of the pig, they surgically operated and removed the thymus of the pig and put parts of it under the capsule of the kidney. They sort of hypothesized that this would make the kidney more tolerant and would make the recipient more tolerant to the kidney. They grafted the organ into the thigh. It was lying exposed, with the femoral vessels were connected. The ureter was cannulated. They used very heavy immunosuppression, methylprednisolone and MMF in IV in very high doses. They continued with mannitol and furosemide to maintain diuresis and used IV heparin to maintain anticoagulation. They basically wanted to prove that this graft will work. And after about 54 hours, the patients died. But just before they died, their creatinine had come down. So these people had functioning kidneys. They were just brain dead. So the creatinine came down to almost less than half. There was dyselectrolytemia. There was hypernatremia, which they blamed on the pre-existing diabetes, the diabetes insipidus, which these people had because of brain injury. And there was hypokalemia, which they placed at the doorstep of the diuresis, which they did. However, after 54 hours, they showed that the organs didn't show any form of immunological injury, whether hyperacute, T-cell mediated or systemic. And of course, there was no genetic evidence of xenozoonotic infection. This was very soon followed by this group from the University of Alabama in Birmingham. They used a 10-gene edited pig where 4 genes were knocked out and 6 genes were knocked in. This picture would hearten they gladden the hearts of the Nari Shakti people in our country. If you look, except for these 4 gentlemen at the back, this entire team is made up of women. This includes the transplant surgeons, the anesthesiologists, and the nephrologists. Again, the graft just before clamps are removed and a nice perfused turgid graft thereafter. They used a 50-year-old brain dead donor who had acute on CKD, but they did a bilateral native nephrectomy before they transplanted the kidney. They gave the patient eculizumab, did induction with methylpred and ATG at 6 mg per kg and rituximab, gave triple drug immunosuppression for maintenance with TAC, MMF, and PRED, maintained a TAC level of about 8 to 10, and took serial protocol biopsies. This organ survived for 7 days. Again, it was a brain dead recipient. The kidney creatinine declined from 3.9 to 0.9, and they demonstrated that a renal xenotransplant can be giving life to a human brain dead recipient with CKD. They claim to have answered a lot of critical questions and gave a lot of world's first as far as xenotransplantation is concerned. And then came the next surprise early in January 2022. This gentleman here in the middle with his son and daughter-in-law is this gentleman called David Bennett. He was so non-compliant with diabetes and end-stage cardiac disease that he could never make it to any cardiac transplant waiting list. And hence, when he was given this chance to try an experimental therapy, he jumped at it and he got this U-Heart, again, United Therapeutics Heart. This was him with Robert Montgomery after his surgery. Dr. Bartley Griffith. Dr. Bartley Griffith is the cardiac transplant surgeon who did the surgery. The gentleman who heads the University of Maryland xenotransplant program is a Pakistani scientist called Dr. Mohammad Mohyuddin. He's been doing xenotransplant in non-human primates for the last decade or so. And he was he had a very important role to play in this transplant. This patient survived for almost 57 odd days. By day 47, he developed diastolic dysfunction. By day 50, the endomyocardial biopsy showed interstitial edema and capillary damage, TMA, complement deposition. They gave him IVIG at one time thinking that he has probably had a rejection. Unfortunately, it increased the amount of anti-pig xeno antibodies because this is human immunoglobulin. And thereafter, they also noticed increasing titers of porcine CMV and the porcine retrovirus in cell-free DNA. There was, of course, antibody-mediated rejection, which was reflected as endothelial injury. And I said, as I told you, the IVIG which was given to him was bound to the donor endothelium, and initiated an immune response. And the reactivation of the latent viral infection within the graft led to a damaging inflammatory response. By the next 2 years later, that is in September 14, 2023, the NYU team again transplanted into another brain dead recipient a kidney which lasted 57 days, almost 2 months. And there they took 180 tissue samples from various organs to assess the effect of xenotransplant, the xenograft on the host. There was mild T-cell mediated rejection, which led to an increase in immunosuppression. They have not clarified what. However, they clearly showed that over 2 months, the xenotransplant functioned normally, maintained biochemical parameters within the acceptable limits, and did not alter the half-life of antibiotics or other drugs in an unpredictable manner, and responded appropriately to human hormones. Then the NYU team went ahead and did a second xenocardiac transplant on 22nd September 2023. This is a video, but I'm not going to show that. Lawrence Fawcett was a gentleman. He was a firefighter. Unfortunately, this organ also did not last for more than a month. But what was clear with these two cardiac transplants was that hyperacute rejection was overcome. Acute rejection is still a clear and present danger. And overall, the heart seemed to be a lesser immunogenic organ than a kidney, but xenozoonosis remained a threat. Since then, no more xenocardiac transplants have been carried out. However, the Mass General Hospital in March and April this year transplanted 2 organs into 2 different patients. I'll come to each one of them separately. What they did is they took a kidney which had 69 genomic edits. The company here was called eGenesis. They removed a large number of genes, which I've already told you, the GAL gene, the endovirus inactivation gene. They added human genes to include complement inhibition, increase anticoagulation, and immune regulation. Look at the immunosuppression they gave. They induced the patient with Ritux, with ATG, and they brought a new complement inhibitor instead of eculizumab, which is called ravulizumab, and of course, induction steroids. In maintenance, they brought a new drug, which is an anti-CD154 monoclonal antibody called tegoprubart, which is, as I said, co-stimulatory blockade, along with MMF, TAC, and PRED. This is the gentleman, Rick Slayman, a diabetic who had been on dialysis for 9 years, was unable to find a kidney because of various other medical comorbidities. Unfortunately, Rick Slayman had a myocardial infarction and he died with a functioning graft almost a month and a half later. This is the NEJM article which came just last week, May 15th, 2 weeks ago, which showed, look at the injections of tegoprubart here, if it's visible. You can see the injections that have been given. This is where the transplant was done on day 0. So tegoprubart and ravulizumab were used for induction also, Ritux and ATG at 1.5 milligrams per kg, steroid tacrolimus and mycophenolate. They gave the ravulizumab till day 28 and day 50 is when the patient died. That is the organ immediately after vascularization, completely fine. That is showing you the Doppler of the graft. You can see here the serum creatinine level after the day of transplant dropped beautifully down to the GFR was in green. As you can see, it rose to almost 50 ml per minute. You can see tegoprubart's blood levels coming down and being maintained here, and TAC level was maintained between 7 to 10. Then they gave this kidney to this lady, Tawana Looney. This lady had donated one of her kidneys to her mother when she was a 20-year-old. Thereafter, she became pregnant and had a pregnancy-related kidney injury and progressed to end-stage renal disease over the next decade. Remained on dialysis for 8 years and could not find a donor because of being genetically sensitized, being immunologically sensitized. She received the next kidney under the FDA's compassionate use program. She is still alive. And on February 7th, they gave another kidney to this gentleman, Mr. Andrews, on February 1st. He has also been discharged in the first week of February. He is also, as of today, alive and doing well. So they all seem to be, they have got the same immunosuppression profile which Rick Slayman got. Our neighbors across the border, the Chinese, have transplanted a modified pig liver into a brain-dead Chinese patient and kept it alive for 10 days. Of course, this is the only detail I have. Thereafter, there is nothing that is available on this. Of course, this is another human interest story. This is David Bennett, the first xenocardiac transplant recipient's son and his family. And of course, they interviewed a lot the people whose the brain-dead recipients whose relatives gave the consent for the organs. And they all had one thing to say, that they have seen their relatives suffer while waiting for an organ to come from somewhere, and they had absolutely no regrets that their relative tried this revolutionary new therapy and it did not work for them, but at least they got some hope. So for those who have issues with these things, this is a good indicator to show how desperate a patient on the organ transplant wait list can be. Which are the firms behind these pigs? This is United Therapeutics, which is in Blacksburg in Virginia, and eGenesis, which is in Cambridge, Massachusetts. United Therapeutics is very interesting because it started as PPL Therapeutics, which was called Revivicor, which made Dolly the pig, the first cloned pig, the first cloned sheep of the world in a university in Scotland, in Edinburgh. This is where the university spun off this company in PPL Therapeutics. They were the first ones to make what is called the GalSafe pig, which was thereafter in 2003, this company came to be called Revivicor. The GalSafe pig was the first one which got FDA approval for as a source for human food consumption, and then later as a source of human therapeutics. 2021 is when the Revivicor U kidney, which is also called the Thymo kidney, which was first transplanted. I have told you the details. In 2022, the U heart, which is what David Bennett got. And in 2023, Thymo kidney was used. And again, it was given to the third brain-dead patient who lasted for 57 days. And a U heart was given for the second human cardiac transplant recipient. To such an extent that United Therapeutics has now got FDA clearance for testing its drugs in the U kidney clinical transplantation. I'll just take you through the details for the sake of interest as to how we have moved from absolutely taking patients who are not desirable at all, who would not have received a kidney, and they died with functioning kidneys, because of which we could really not test the survival and the efficacy of our organs on a long term. Now we have an actual clinical program. The study design is very interesting. They claim it to be a phaseless study. That is, phase 1, 2, and 3 all are going to be done together. Safety, efficacy will all be done seamlessly without moving from phase 1, phase 2, and phase 3. I guess all of us understand why. The organs are so expensive and the numbers are going to be so few that we can't do a step-by-step phase study. What they're going to do is participants will receive a kidney transplant followed by 24-week post-transplant follow-up period during which they will assess the patient for various endpoints. I'll come to that. So what they have clearly said is that they will look at patients who have been assessed and determined to be ineligible for a conventional kidney transplant for medical reasons, and those who have been on a wait list but are likely to die or go untransplanted within the next 5 years. So 5 years is a decent enough period, I would say, unlike the people who are almost dying whom they took this time. What are the efficacy endpoints? Of course, patient survival, kidney survival, change in GFR, change in quality of life. Safety endpoint would also include adverse events, serious adverse events, all-cause mortality, proteinuria, zoonotic infections, and opportunistic infection. And who will they take? 55 to 70, diagnosis of ESRD, at least 6 months of dialysis. They would definitely not take people with a history of medical non-compliance. They would exclude patients with severe medical comorbidities like advanced cardiovascular disease, severe peripheral vascular, severe neurological, and chronic pulmonary disease. So what I'm saying is gradually we are moving towards looking at recipients who are likely to be better and more sturdy and likely to benefit and live longer with the organ than die of unrelated issues. I do not know how many of you know this gentleman, Dr. Barua from Guwahati. He actually did a transplant in India, a cardiac transplant in Guwahati, from a regular pig into a human being. And he gave that gentleman plasmapheresis. There was no IVIG in those days. This was in the late 90s. Patient died, of course, after 3 days. He was arrested, spent his time in jail, is now living a very quiet life after having sustained a stroke. So that's it from my side on this topic, ladies and gentlemen. It's very interesting. There's a lot of reading material. Like what Mr. Barack Obama said, we have to acknowledge the progress we have made, but we have a long way to go. Things are better, but they are still not good enough. And you may think that you have a long way to go, but sometimes we need to look back to see how far we have come. I'd be happy to take any questions.